what it is. What is that? It treats, there we go. Primarily basal cell carcinoma, squamous cell carcinoma, head and neck, some larger areas on the trunks and extremities, we may utilize it. And it makes a lot of surgical defects. And that's where you guys come in. A few years back, David Lang, who most of you probably know, just kind of in a social setting said, hey, to use allografts. And at the time I was playing around with an AmnioArmor Graft and also the ECM, organogenesis product. Wasn't sold on them, didn't have a lot of instruction on how to use them, was just basically placing them and seeing what I thought. Hadn't really captured me as a user. So I told him a little bit. He told me about his AmnioArmor amnion patch. And I said, well, listen, David, I'm glad to try it and see how it works. And long story short, with a lot of ability to kind of practice on some samples, utilize it, it's now a huge part of my surgical practice. I don't know the number, but probably 3 to 4 a day, daily use on MOHS defects, primarily in sites that I would say are large defects in areas that are in concave surface areas of the body, head and neck, that are options for second intent, but often that's a very long, protracted course of healing, which is essentially not, allowing it to heal on its own. But more importantly, for a lot of my patients that are super seniors, those 75 and up, and even older, a lot of times these really large cases would end up in the plastic surgery and operating room suite or surgery centers under general anesthesia. And I've found these grafts have been a great addition for those patients because we get great healing, very good cosmesis, but more importantly, low morbidity. These patients just come in, weekly skin, we're doing the wound check anyway, but lay another graft, and pretty amazing results, which you'll see on a few of these slides. When you're talking with physicians, some of them like to be nerdy, myself included. So basic science isn't a bad thing. There's a lot of reason why these AmnioArmor grafts are pretty amazing healing, and a lot of it's in this slide. It's a busy slide, glad to share it with you, but it has to do a lot with the angiogenesis, anti-inflammatory, regenerative effects. There's a natural antibacterial effect, which is, why we see very little infection when using these, much less than when we would allow things to heal by second intent. But most importantly is how quickly these are healing. And a lot of that is the science behind cytokines and these, receptor binders that are causing all this quick healing. First case I ever did, this gentleman just specifically did not want a flap or a graft, which skin flaps are when I locally move tissue, maybe from over here, a back cut, and rotate it over, or transposition over. He didn't want that. He was very well educated. He said, I just don't want that. That sounds like more bleeding. I'm on blood thinners. And so I said, we can do a full thickness graft, taking from skin from the other side of the hand where I had a little more movement. He didn't want that. So I said, well, I have this sample of an allograft, and he wanted to try it. So we laid the first one. This is the very first one. David's calling me. David, I'm on the call now. Can you hear me okay?
I can hear you. You were able to get in one?
Yep, I'm on.
Okay.
Hey, David's having trouble, so maybe help him. He might be locked out of the room. So this was the very first one I put down. What you can see here is I didn't get a picture pre-hydration, but this is post-hydration. The graft actually dissolves kind of into the wound. So you're not going to, the physicians should be aware, and I was not aware the first time I used the AmnioArmor that it's not, is hardy, and it kind of, that one is even thinner and it really dissolved in, but it kind of dissolves in, but you can still manipulate it once it's hydrated. And that's the key that I've found. So once, and this graft was a little oversized because it was a sample, but once and this is 1 week. So just so you can kind of go back and look, that wound in 1 week had already healed to that, which that's not normal healing. Okay. People don't heal that quickly, but these grafts are allowing that. Placed a second one, which you can see, it's a little larger than need be, but again, this was a sample. But once I hydrated it, I kind of tucked the corners around the healing end of the wound, which I think is really important to allow more of that centripetal healing from the exterior end. So here he is 2 weeks out, placed a third, and then that was him completely healed when he came back for, a few weeks later. So that's pretty impressive. I mean, I don't know that, anyone could get a wound healed that quickly and looking that good. And now that little bit of pink has faded and you can hardly tell. So that's the beginning, that's the end. So 3 allografts, for the most part, a lot of physicians might go, well, how many is it going to take? It really depends, patient specific, someone on their healing, but also the site location. I've had head and neck ones. It only takes 2 or 3. I've had lower extremity, ankle. I've gone all the way to the max allow, which is 10. It just depends. This is how we bandage it. And this is a slide David has that's available for you. Hopefully he got on. It just shows kind of the way we bandage after the graft is placed. We put a Xeroform gauze down. We either Steri-strip it or tape it on, non-stick Telfa. And then for the leg, I usually just use Coban and wrap it, but you could tape it down too. And that's another pretty deep wound that's pretty amazing. After 1 graft, he'd already had that much healing. This one, I like to show the Mohs surgeons when I get to talk to them, because we all have these defects, large squamous cells that are very deeply invasive, aggressive. The pre-op size when I started this case was about the size of a quarter, and it was, much more aggressive in the deeper aspects of the wound. So we're down to calvarium, which is essentially bone. Now, once you go below the galea, which is this tissue layer that overlies the bone, we were always taught, you can only do a full thickness skin graft. So this gentleman, close to 80, I think, is his age. His son really did not want him going to the operating room, because that was really the first option. So let me go over some closure options we discussed. So a large flap, a large rotation flap, and I showed this to his son. I would have to cut from here pretty much the whole way across the scalp. Undermine all of this, a lot of bleeding. So lift this whole flap, rotate it over, and truthfully, it probably wouldn't have closed the entirety. Probably would have had an opening about that size. He wasn't a big fan. Patients, elderly, and that with blood thinners that he was on could have turned into a really problem post-op. Full thickness skin graft. I mean, the question is, where are you going to get that large of a graft? Not many. I can't think of anywhere. Now, plastics might use balloons to in the operating room to try to stretch skin to pull a graft, but again, that's operating room intubation, high risk for a gentleman this age. Split thickness, again, you can take one from the leg. It would never heal. It would just kind of keep this whole drop off likely, and not a real good likelihood of healing, just because that's basically just a thin layer of skin trying to go over bone. Referral to plastics. Again, 3 years ago, a lot of these patients, I would have just said, listen, this is really large. I think maybe better suited to plastics. It wasn't that I wasn't thinking about the morbidity of that for my patients. I just, a lot of times, if they brought it up, I would say, sure, let's go that route. But now I, try to discuss, what would I do with my dad kind of situation? Allograft. So this is an AmnioArmor graft. So I went ahead and placed the first one. 1 week post-op. So you can see that bone's completely exposed there. Place the graft, and that's post-hydration. So it was a little oversized again. I mean, they're never fit perfect, but what I do is I hydrate, and I have a video to show you. Hydrate from the periphery, and then use that excess tissue around the tissue edge. Oh, sorry, that slide was supposed to be more dramatic. It was supposed to float in at the end, but 4 grafts, okay? And this was a month post-op after the last graft was placed. This is a slide I'll share with you all, and David can, which, I mean, you don't have to say a lot when you show this. I don't know of any closure of plastics could have done that could look this good. I don't know. There's definitely nothing that could have been done that was less morbidity for this gentleman. And the family was ecstatic, blown away by what we were able to do. And frankly, I was too. I mean, this was just a case that was a wow. Melanoma cases where I use what's called staged excision. Those are great cases for these grafts because we're cutting down the cartilage here. Here I doubled over a graft because it was down to cartilage. but you can see 1 week, he'd already had perichondrium forming over that cartilage. Again, that doesn't happen on its own. There's a lot of healing that's beyond what is normal when these allografts are placed in a good way. And here it is placing a second one. Now I'm about to pull this slide out, but I kept it in for a reason. So when I started, again, I've probably done more of these than anyone in the country, AmnioArmor that is. It's a learning curve. No rep had ever given me instruction with EpiFix or PureApply or the other grafts. So I kind of tried them and wasn't real, but this obviously I've been using and learning and teaching. So we would always use a bottle of normal saline, soak gauze, hydrate it with that. Then there was a shortage McKesson had of these bottles of normal saline. So we made a pivot. I'm going to come back to that in a second. This case I always like to share because it's again, a melanoma, which doesn't look like it's going to be very big. I should be able to stitch that up after I clear the margin if it's no bigger than what you see there. Unfortunately, stage 1, stage 2, stage 3, stage 4. It got really big. And of course, his daughter is an attorney from California who wanted to FaceTime the entire time and was very much thinking her 80-year-old dad needed plastic surgery. I gave her the wisdom of, listen, had a recent case, blew me away using something that doesn't hurt to put on, only takes a few minutes, and your dad really doesn't need to be in an operating room. So this picture here is good because it shows, because with this surgery was done over 4 stages and it was over probably a week and a half duration, I already was getting some superficial healing on the medial aspect. I was chasing it on the deeper aspect. So that area is deeper. So what I did with the allograft is I actually used the excess to kind of tuck into the deeper areas. And that made a lot of sense because we already had healing on this end. We wanted this side to catch up. So here you can see post-hydration kind of tucked in. And this is kind of following it through. And I did this one right. So there's his defect. And here he is. And I've seen him since, and you can't even tell there was a surgery. I mean, it matches perfectly. And nothing we could have done could have been better for that patient from a cosmesis standpoint, but also from a just morbidity standpoint. This was a young patient, a wound care nurse. She wanted to go to plastics. Plastics delayed her 2 weeks, which isn't bad. It just means they would probably have to recut the edges and freshen it up before doing the flap. I had drawn a flap I was going to do, but once a patient brings up plastics, I generally check my ego and say, okay, we can do that because you want them to be, their expectations to be met. And even if I do an amazing closure there, they'll always think, did plastics, would they have done it better? So I say, yeah, sure. But while we're waiting, why don't we try AmnioArmor? We did. And I'm sorry, that picture, let me move it over. Oops. We did. And by the time she was getting ready to go after 2 of them, she said, let's put a third. And I've seen her since. And again, you can't tell I did surgery there. She was very happy. And especially as a wound care nurse, she knew all about allografts and had never used this one. Here's one serial. You can see week after week. What's important on the first picture is the defect exposed cartilage. So when you're talking to physicians, they may say, well, I doubt it would work on cartilage or bone. Well, I mean, here's the proof. First graft, second, third, fourth. So you can see how amazing that endpoint was. So really, for most surgeons, this has been probably the greatest thing about it. I have a very busy surgical practice, so much so that my demand sometimes outpaces my abilities to keep up with it. Well, allowing these large defects, rather than spend an hour and a half doing a huge flap on the scalp or an hour doing a full thickness skin graft on the ear, I'm able to basically clear these tumors, set up a 1-week follow-up to start the allografts, start the AmnioArmor grafts. And these patients are able to, just go ahead and move on from the clinic, and I'm able to move another MOHS in. So roughly 2 to 3 cases have been added a day since I've utilized this product, which is to me the most important thing because, I'm dealing with skin cancer in the panhandle of Florida, which is about the highest incidence in the country. So I'm doing a lot of cancer surgeries, and this has really helped the workflow. This last picture, and I have another video I'm going to pull up, is I showed you that bottle that McKesson, well, when McKesson had a shortage of that, we ordered from them, and David has a order, sheet. Let me see if he was able to get, David, are you on here now? I don't know if he is or not, but he can share with you the ordering. These little ampules, they're absolutely, I just used them because that's all I had, but now they're my go-to. I'm able to hydrate these very pinpoint and manipulate the graft with forceps. So these have actually really helped my skill in utilizing these grafts rather than just putting a gauze on it and hydrating. So I've got a video. Let me see if I can pull it up. I'm going to stop share just 1 second. Bear with me here. Any questions why I do this?
Where are you based, doctor?
Destin, Florida,
Okay. All right.
but I
Thanks.
practice all between Pensacola and Panama City.
Okay.
I'm on the struggle bus here with this video. 1 second. But the main thing I think for you guys is be a part of this team. You want to kind of give the physicians guidance because you may think they know all this. These allografts are kind of new territory for a lot of them. So they need some kind of instruction. Here's how this doc's using it. Again, I'm happy to speak with them and even just to show this video, which I'm struggling here. Let me see here. I don't know if this will work. We're going low tech here. It did not send over for some reason. All right, I don't know if this is probably not going to work. It's sent over as a file and it wouldn't open up. But give me 1 second. Let me try this again. Any other questions while I bring this up?
Yeah, when would a flap or a full thickness skin graft be more appropriate?
Well, again, my younger patients, I'm usually going to be a little more concerned about, they don't like an open wound as much. It has to be weekly cared for, coming in weekly. So I often, will do like the young lady, I probably would have done a flap on her had the situation not been that she just wasn't able to get into plastics and really wanted plastics. So that's where I use it more. And I still do a lot about, flaps and grafts. I just have worked this in particular for large defects. My older patients that I worry about going into plastics, because a lot of times their children are there. I show them then defects so they understand what we did. And a lot of times they immediately think, okay, he needs to go to a hospital, in an OR, not thinking about these patients are probably the last thing we want to do is take them to an operating room if we can avoid it.
Thank you.
Yep. All right. This video might not show up well doing it this way. It's just not opening up for some reason, but I use those little ampules. So when I'm laying the graft, that's not showing up well, is it? Sorry.
I believe that Zoom believes that's part of your background is blurring it accordingly.
Blurring it. Wonder how is my background. Teach me guys Zoom here. Where do I unblur it? Let's see.
Could be on the pop-up menu of the start video in the bottom left-hand corner.
Okay, thank you. Let's see if that works better. All
Hey,
right,
Mike.
yeah, good call. Yeah,
Can we talk about the process of getting it set up to schedule a call with you and getting that sort of, that set up?
yeah. So my admin day where I'm not doing surgery usually is Friday. Now, that being said, a lot of docs might have time on Friday, but if they do not, and they just want, you're taking a luncheon for them, which, by the way, this is a little pearl I've given. I don't know if some of you are on the call. This is redundant, but if you can take a luncheon, usually the docs will give you 10, 15 minutes because you're taking care of their staff, giving them some something to eat in the middle of the day. That we can time that, and I can kind of put a block on and say, hey, get to jump on, run a few slides with you, get a little more tech updated and show this video. But that's probably the best way for me to coordinate with you is just give me a heads up when it is. But Fridays, I'm pretty open. So if you guys work on that, it can work on that day. Happy to talk with them and tell them how kind of worked it into my workflow. I'll show you this video real quick here. I think good call on the background. So this is actually a newer graph we're working on, but I'll show this to you. So you can see it's not hydrated there. And then what I'm doing is using that little ampule to hydrate it. And then once I get it hydrated, it's already going to be partially hydrated by the wound bed because there's, serosanguinous fluid there. Then I can take forceps and kind of tease it in, gently tease it in. And we're using every bit of that product. And it's important for the surgeons to document the three-dimensionality of these wounds because for an audit purpose, we're using the length and width, obviously, but we're also going to use all the redundant. We're not going to throw it out because these are deeper wounds initially. Now, in the end, I'll order smaller grafts because then they become shallow wounds. And I don't need, but initially, I like to tease it in with this. But those little ampules, we'll make sure we get you those because for me, they've been a great addition. I can control the hydration better. So very happy with that. Okay. Sorry I had to do it that way. I just couldn't get the file to open.
And then how do you dress that, doctor?
So immediately put that non-stick, the Xeroform gauze on, Xeroform, which is kind of impregnated with the Vaseline material. And then non-stick Telfa, tape that down. Sometimes we'll stair strip the Xeroform in. But ultimately, I leave it on for 48 hours. Sometimes, if it's a patient that can't really tend to their bandage, we'll bring them in at 3 days and take it down and then start using just antibiotic ointment on the wound. After 3 days, the graft has done, the allograft has done what you want from a standpoint of the, nutrients and all the things that are happening from a, healing standpoint. So if people see kind of the redundant piece, like at the next bandage change, you may see some of that graft. It's done what it needed to do. If the patient says, "Oh, it's there's still pieces," yeah, but it's kind of done all the work we expect after a week.
Do you find when you come bring the patient back in, will there be any type of debridement that you'll do, or is there good granulation that is coming in and you just continue treatment from there?
Yeah, great question. So I debride every wound each week, but I just put some Hibiclens on a dry gauze and just do kind of gentle debridement. Rarely do I get the scalpel out and debride edges unless it's an ear and cartilage was exposed and maybe it's just stalling a little bit. I might use it then. Scalp too occasionally when I'm down to bone. But for the most part, it's just a dry gauze. I'll put some Hibiclens in the wound and then debride.
Okay. Two questions, and they're a little different. Number one, from a insurance reimbursement standpoint, typically in the wound care field, it's like 30 days out. How is that different on the MOHS type? You know what I'm getting at from the standpoint, because when they come in with a situation like this,
yeah,
you're probably wanting to treat that immediately.
So the wound care, they make them wait 30 days to use them. Is that what you're saying?
Yeah, usually like on a diabetic foot ulcer, those types of things, takes up to 30 days. If it's not healing, then a skin substitute is
Gotcha.
reimbursable.
I don't
How is
think they hold us to that. Yeah, we 1 week post-op, I begin them because that's the right thing. You know, you want to go ahead and get that thing healing. I like to give a week just so I can get some granulation and some natural healing to start the process. But we don't, you know, the wound care folks, they have different rules because
okay. Okay.
yeah, so I don't know I know 10's usually the allotment they can place on, you know, 10 allografts. Yeah.
Right. The other subject I would, when we're talking to a doctor as yourself, what can we expect maybe from either obstacles or pushback from a doctor that has not utilized this product before?
Yeah, so I kind of lump most surgeons into a couple different camps that will help you guys. There are some that are, you can't teach an old dog a new trick. Okay, you're going to go in and you're immediately going to get pushback. I can do a beautiful full thickness skin graft, you know, and I don't even
Right.
need to hear about this. Don't waste your time. You're not gonna get through to those most surgeons. Now, the busy high volume practices that, you know, are in the situation I'm in, you know, we're always looking for innovation. We're always looking for ways to help our patients, but also the burden of the workflow. That I think that's a huge thing that to hit. You know, I told David when we started, we actually got paid, I think, half as much as what we do now. And I said, David, I don't even care if we make a dime off these things. What it's doing for me is letting me keep up with the demand, you know, which was, you know, a constant stressor. You know, 2 weeks, I don't want an invasive squame waiting more than 2 weeks, you know, and
Sure.
I'm always chasing that. So that's the thing. So those busy practices are probably the best ones. I'm not going to say younger physicians because I'm kind of getting to them. I've been practiced 20 years now, so I'm kind of pushing to the other side of that. But people that are newer in practice tend to innovate more. That's just an experience. But you know, I can help you. Mohs surgery is not a huge world. I know a lot. I can probably give you some, you know, inside scoop on what I am guessing is going to be your Mohs surgeons temperament towards using allografts, but most of them, once they use it, the ones we've had try it have kind of been like me and been like, wow, I wish I would have found this earlier, you know, or been using this earlier. So
Okay.
just getting them to give it a try, especially showing them some of those pictures, the ears and scalps. Everyone's looking for an answer to help those wounds.
Sure. Okay. Thank you.
Yep.
Dr. Stickler, this is Lamar out of Birmingham, Alabama. Can you hear me?
Yes.
So my question is more to the point of when you're doing your one-on-one talks. I have two surgeons now, Mohs surgeons, both young, one owned by UAB, one owned by a private large group that want to speak to you, but they both want to graft. Both are familiar with grafting. Both are Mohs surgeons.
Yeah.
The problem that we're running up against is not that they're wanting to try. It's battling the owners of their clinics because I'm coming in behind Revita, Affinity, Epifix,
Right.
Dermacyte, AmnioAmp. Like I've got about 5 or 6 competitors in these offices currently.
Right.
So I'm curious, when you do your talks, are you able to touch on not necessarily your relationship with David and how early you began your practice with allografting, but specifically one against another and your experience there?
Sure. So I think that's a great point that I forgot to bring up when you're looking at, and I hate that the landscape has become this, but derm has become largely pushed, private equity's pushed in. You have mega groups. You know, I don't want to say don't bother, but here's the truth. You know, I own my group. I'm one of the 2 founders of it. When I wanted to try this, I just said, I'm going to try this, right? You know, it was that's the extent, you know, I did go talk to my medical advisory committee, which is I'm on obviously. And there's about 4 other physicians on it. And, you know, talked about, hey, I'm going to do some trying this. And once I loved it, I said, hey, I'm bringing this to my practice. Take a look at this. You want to try to target the smaller Mohs surgeons that maybe you know, they own their practice, because the large groups, they usually have to go through layers of administrative to get there. And you could have a physician who really wants to try it and never get to the point they can, or they're allowed, which is unfortunate, because I think that's a hindrance to good medicine. But I'm getting on a tangent. So what I would say is fine tune your targets to try to find most surgeons or practices that are, 1, 2 locations. They own it. They're not part of a big private equity group or a university. And unfortunately, you'll probably get better return on folks being able to try it and utilize it, because that's just the world of medicine now. So that was a good question though, because I've helped with a big, large group in Florida, and we still haven't got them past the medical advisory committee they have, because they meet like quarterly, and they're like, well, we'll talk about it, in June. And it's like, okay.
Thank you.
Yep. But there is some public domain information on like people that do a lot of MOHS. You can look on and find out about through the Medicare data, and those are the patients or the practices that I think just from the workflow standpoint, it's going to help a lot. Any other questions? But just know I'm there for you all if you need anything, okay?
Well,
Thank you.
what's the best way to contact you?
David can send out after this, my contact. Probably email me if you're trying to coordinate, because I check my email throughout the day. Phone, I kind of put away during the day and get to it later. So if you just email me, if there's a meeting you want to try to set up to coordinate, or if there's any questions, obviously, we'll get you that information.
Thank you, Mike.
Thank you. I had one question. So do you manage expectations at all with your patients? Like some of those pictures of the healing, especially that on the scalp, the robust healing is really impressive. Is that something that is, I don't know, I guess, how do you manage your expectations of your providers and patients or excuse me, your patients?
Yeah, well, I mean, I think what you have to just make sure is they understand, again, why we want to try this over going to the operating room. I'm just very upfront with patients and talk about, well, the cost of going to an operating room with plastics is, $30,000, $40,000. But more importantly is the morbidity for senior patients to be in that setting. Often things you may not hear about it, but then later you'll hear, oh, so-and-so got pneumonia after their surgery, and then they got in the hospital, and then they got a pressure sore, and then things spiral with some of our senior patients when they go into that setting. So I talk about options, but I also talk about expectations of what we're going to get. And weekly visits, I kind of like to see these wounds weekly anyway, so it allows me to kind of watch the healing, watch for any infection. But knock on wood, that antimicrobial effect of these, these open wounds are far less infected than when I would leave something second and 10.
Right. Thank you.
Yep.
Hey, Dr. Stickler.
Yes.
Yeah, hey man, what do you think the most effective way to get the attention of the office staff is and get time with the surgeon? I imagine they protect the surgeon's time. Like, what's the two most important things to mention to them? Is that workflow and results?
Yeah, when you walk in, you might not get FaceTime with a physician, but I think if you if you feel like you're not going to get that just by coming in and saying, hey, I'd like to talk, then just bring up, hey, can I talk to your office manager maybe about setting up a lunch? And then when you talk with them, say, do you think the doc could give me like 5 minutes, just during the lunch, just to go over a little bit, or, let me zoom in and just show some cases that another surgeon's using. And whether, I think that's the route, because I don't see reps during clinic. I don't stop clinic, but I do allow, some time if someone comes in for coffee in the morning or lunch. That's my policy because I'm busy, but you might walk in and the doc's like, yeah, come on back. And that's great. But if not, I think that's the better way to work through the office manager to maybe say, love to do something for the staff one day. And, you know, that's usually the door in because they feel a little bit obligated to come give some face time. And then you can kind of get that one-on-one and talk a little bit. But you might find they immediately say, yeah, I don't use these, but thank you. And that's the end of it. So that's why you got to do a little homework. All right, any others? But again, I'll get you my contacts, and if anything comes up, just reach out to me, and we can kind of talk offline.
And Dr. Stickler, you said
Great stuff,
these
Dr.
are-
Stickler. Appreciate it.
Yep,
Thank you.
You said these are applied 1 week post-op?
that's what I do. I mean, you could put it on immediately, or you could wait a day or two. I just like a week because it gives some healing. That's just my kind of protocol.
Thank you, thank you.
Yep. All right. Well, if there's no other questions, again, I'll get you my contact. Feel free to email me. And I'll get that video. I'm going to put together a video that's has like a voiceover instructional that might be good to show. I'm just not the most tech savvy guy, but I'm gonna work on that for you all over the weekend. Okay.
Thank you very much.
Thank you.
Thank you.
So much.
Thank you, Doc.
Thanks, Doc.
All right.
Thanks again, Dr. Stickler.
No problem. I know Tim's not on, but if there's nothing else, have a great weekend.
You too. Take care.